اوكي. بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على سيد المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه وسلم أجمعين. أتمنى جميعا أنكم بتكونوا بخير وإن شاء الله تعالى يكون اختبار الميد تيرم كان هين عليكم. تجربة طبعا هي نحكي نسبيا الوضع اللي احنا قاعدين فيه جديد علينا جميعا، لكن انتوا اثبتوا ما شاء الله جدارتكم وتعاونكم ما شاء الله. جميع الطالبات قدموا الاختبار وفي درجات كانت ممتازة، في درجات 25 من 25 وفي 24. ومثل ما وعدتكم بالإعلان اللي أرسلنا لكم إياه، كل الإيميلات اللي وصلتنا أنا ودكتورة هديل رح نتعامل معاها خلال هدول اليومين ونرسل لكم الردود، واللي إلها درجة إن شاء الله بتاخدها، وما إلكم إلا تكونوا راضيين. بالنسبة لمحاضرتنا اليوم حيكونوا آخر محاضرات الأسبوع هذا والأسبوع القادم هي practical applications لل most commonly used drugs considering their pharmacokinetic applications. They are most commonly used and most important. طبعا sure we have other drugs that are commonly used, but we are focusing here on 4 different types of drugs. We will start our lecture today with the sample pharmacokinetic calculations in practice with the aminoglycosides drugs. So the objectives of this lecture today is that at the end of this lesson you should be able to discuss why aminoglycosides need special dosing considerations, why specifically we have started with this group or class of drug, and we are discussing the pharmacokinetic for these drugs. Next, you should be able to describe the clinical monitoring parameters of aminoglycosides. Then you should be able to, as a student, explain the effects of disease states and the patient conditions on aminoglycosides dosing. And applying, finally, you should be able to apply the dosing determination methods for aminoglycosides. This is the first class of drugs that we are going to discuss during this lecture. So as an introduction, just I want to mention that our reference or textbook will be a clinical pharmacokinetic examination. I will try to download the book on the Blackboard. It will be available. If somebody can achieve it as a PDF, please send it to me by email. Hopefully I can just assign it on the Blackboard for the old students to be able to study. Otherwise you can continue with our lectures, the slides as well as our show, as well as the tutorial sessions given by teacher Naifa. So the concerning the introduction, we are knowing that the aminoglycoside class of antibiotics these are antibiotics that are bactericidal. Bactericidal, i.e. they are killing bacteria rather than static inhibition of its function. They represent the class of drugs whose pharmacokinetic has been studied more extensively than any other. The pharmacokinetic distribution of the drug inside the body concerning ADME, absorption, distribution, metabolism, and elimination is highly affected by the patient condition and concurrent administration of other drugs or whatever. So the pharmacists are expected to serve as expert on the pharmacokinetic doses of these drugs, and yet complex issues still lead to misunderstandings sometimes in their optimal use. So still there are a lot of studies concerning the pharmacokinetic dosing approaches for the aminoglycosides. Uh, what about the pharmacokinetic for aminoglycosides? The bioavailability, the aminoglycosides, examples for aminoglycosides, bactericidal antibiotic are or antibiotics are gentamicin, amikacin, niclomycin. The aminoglycosides are highly water soluble and poorly lipid soluble. So as a result, they are poorly absorbed when they are administered orally. As a general rule, for any drug to be absorbed, it should be soluble. Okay, we should bypass or the drug should be able to pass the problem of dissolution or solubility. Then it should be absorbable. Which of the drugs is more absorbable through the biological membranes, gastrointestinal membrane? It is the drug that is more lipid soluble. Okay, so we should be able to compromise between these two facts, solubility, okay, as well as absorbability or penetrability or permeability across the biological membrane, gastrointestinal membranes. So since they are highly water soluble and less lipid soluble, they are poorly absorbed through the gastrointestinal membrane when they are given as an oral dosage forms. The volume of distribution, since they are highly water soluble, poorly lipid soluble, of the aminoglycosides, it's around 0.25 liters per kilogram. So say that the patient is, as an example, 100 kilograms, so only 25 liters, okay? So it's a relatively small volume of distribution. Why? Because the drug is not highly lipid soluble. It is not distributing itself and hiding itself inside the adipose tissue. So although a relatively wide range of 0.1 to 0.5 liter per kilogram has been reported. So what we are talking about here, that the aminoglycoside group of a drug, it has a wide range of volume of distribution ranging between 0.1 up to 0.5 liter per kilogram, with different types or with different types, yes, drugs inside the aminoglycoside class of a drug. As I have told you previously, we have gentamicin, amikacin, niclomycin, tobramycin, and others. But the most common value is the 0.25 liter, or the averaged value is the 0.25 liter per kilogram. Okay, and it's relatively a small volume of distribution. Since the aminoglycosides distribute very poorly in the adipose tissue, why? Because it has poor lipid solubility, it has high water solubility, it has poor absorbability, okay, it has a very small volume of distribution, it cannot be distributed in a wide range to the adipose tissue, lipid tissue. Then lean rather than total body weight should result in a more accurate approximation of the volume of distribution calculation in obese patient. What do we mean by lean value? It's the muscles weight regardless of the lipid weight. Okay, so in the obese patient, we should consider or rely on in our calculations, pharmacokinetic calculations for the aminoglycosides, on the lean weight, the actual muscle weight, rather than the total body weight, including the lipid weight, because the drugs are not widely, this class of drugs is not widely distributed in the fat tissue. Okay. So, in our case, the aminoglycosides volume of distribution in the obese patients will equal 0.25 liter per kilogram multiplied by the ideal body weight, okay, plus 0.1 multiplied by the total body weight minus the ideal body weight. Okay, this is to rely more specifically on the lean body weight rather than the total body weight for obese patients. Okay, the volume of distribution for aminoglycosides increases in patients with ascites and edema. Definitely, you should be able to understand the answer. Why, or the explanation? Because it's highly water soluble, okay? Then it will be more distributed in the fluid accumulation, aqueous fluid accumulation in patients with ascites and edema. Okay, one approach to approximate the increased volume of distribution. Now, this is the equations that are showing you, and they have been exposed to you previously, that the ideal body weight for males is around 50 plus 2.3 multiplied by the height. The height should be present in inches value, where the inch equal to 0.54 centimeter minus 60. The ideal body weight for females in kilograms equal 45 plus 2.3 multiplied by the height minus 60. So back again, one of the approaches to approximate the increased volume of distribution for patients with ascites and edema is to increase the volume of distribution by 1 liter for each kilogram by weight gain. Okay, the weight gain is not due to obesity, not due to the lipid mass. It's due to the presence of ascites and or edema. For the volume of distribution in children, okay, so you should take care about this value, which is increased 1 liter per kilogram per each kilogram increase that is due to the ascites or edema. Okay, for the volume of distribution in children, the aminoglycosides volume distribution in liter in children that their age is around 1 to 5 years will equal 0.5 liter per each kilogram, okay, minus the age in years multiplied by 2.25 multiplied by the patient weight in kilogram. After 5 years of age, the volume of distribution of 0.25 liter per kilogram is generally used. Okay, another time, why 0.25 liter per kilogram for older ages and why 0.5 liter per kilogram for younger children? Because as the person become older and older, the adipose tissue will be more, so it will be decreased the volume of distribution, while vice versa will be applied when they are young. Okay, let us talk about the clearance. So as a first step, we were able to calculate the volume of distribution for obese patients and for children that are below from 1 to 5 years and for children after the 5 years of age. Now, when we want to talk about the clearance, the aminoglycosides antibiotics are eliminated most entirely by the renal route. Mostly by the renal route. So since the aminoglycosides and the creatinine clearance are similar over a wide range over renal function, so the aminoglycosides clearance can be estimated from the formula used to estimate the creatinine clearance, very similar to, if you remember, just the previous week we have talked about the clearance as an example for digoxin, where we have renal clearance and non-renal clearance, as you can remember. So There is a direct correlation or relationship between the clearance of the aminoglycoside drug as well as the renal functionality, which is expressed by the creatinine clearance. Now, the non-renal clearance for the aminoglycosides is only 0.0021 liter per kilogram per hour, or 2.5 milliliter per minute for 70 kilogram subject, which is very few or small value. This is indicating that the drug is mostly cleared. Aminoglycosides are mostly cleared by or eliminated by the renal route, entirely eliminated by the renal route. The non-renal elimination is very small value, as you can see. Now, the aminoglycosides antibiotics are given as short-term half to 1 hour infusion. Gentamicin, amikacin, nitlimicin, tobramycin, they are given intravenously as a short term, half hour to 1 hour. If an 1 hour infusion is used, the maximum end of infusion peak concentrations are measured when the infusion is completed. Now we will look at the figure, which is 4.1 in the next slide, and I will repeat what I have mentioned here. I cannot just go forward to the image and go backward. The recording voice will be omitted. So just I'll read for you now what is written here and explain it. Then I will re-explain it back again when I'm switching to the next slide containing the plot. So back again, for a 1 hour infusion, the maximum end of infusion peak concentration are measured when the infusion are completed. For half an hour infusion, if it is used, the serum concentrations exhibit distribution phase, so that the drug in the blood and in the tissues are not yet in equilibrium. Drug in the blood beside drug in the target organ, where is the infection or bacteria inflammation or infection, yet the drug concentration in the blood and the tissues are not in equilibrium in the case of half an hour administration period. Because of this, half an hour waiting period is allowed for distribution to finish the half an hour infusion if a half an hour infusion is used before the peak concentrations are to be measured. Now I will re-explain on the figure what I have been mentioning here. Okay. Look at this figure or at this plot. This is the dosing approaches for the aminoglycosides. We are following the conventional dosing method. What do I mean by conventional? تقليدي. Okay. المتعارف عليه. لسه ما عملنا. We didn't yet make modifications. Okay. Now, first of all, you should take a look at that plot. Please, for pharmacists, we should, a lot of plot, a lot of figures, they are summarizing chapters or even slides. You should be able to characterize the plot, the x-axis, the y-axis, the curve, and what is it talking about, this plot? This plot, its name, it is a concentration time plot for gentamicin, which is an example of aminoglycoside bactericidal antibiotics. Okay, so the concentration is the x-axis and the time, sorry, the concentration is the y-axis. The unit is microgram per milliliter. It's a drug or plasma concentration for gentamicin on the y-axis, plotted versus the x-axis, which is the time in hours. Okay. This is the concentration time plot for gentamicin, which is given at a dose of 120 milligrams, given as a half an hour infusion, okay, which is the square with solid line. this solid line with squares, it's the administration of the 120 milligrams of gentamicin intravenously over an infusion period of only half an hour. And a 1 hour infusion, which is the circles with the dashed line. Circles, these are the circles with the dashed line. So let us take a look about this plot or this curve. We have administered the patients. Usually these are average values for example, 6 patients or even more undergoing the clinical phases or real patients. We are taking at 0 times, say at 8 a.m., we have been administering these patients with 120 milligram intravenous infusion. For patients with squares, the 120 milligram has been administered over half an hour. For patients with circles, the 120 milligram has been administered as an IV infusion over 1 hour. So the dashed 1 hour, this or the circles 1 hour, the squares half an hour. Look at this. In the case for circles, after 1 hour, when we have measuring the concentration, an equilibration has been achieved for the drug concentration between both the blood and the tissues. But this is at 1 hour, okay, after the end of drug administration. But for the half an hour period, okay, when we have measured the drug concentration after the beginning at 1 hour, look, there was a redistribution of the drug concentration between the blood and the tissues. But at the end of infusion at simply half an hour, the drug concentration in the blood is very high, and yet compared to the drug concentration in the tissues, and yet the equilibrium between drug concentrations in both blood and the tissues hasn't been achieved yet at half an hour. We have stopped at half an hour. The total 120 milligram have been given to the patient. The equilibrium has been achieved not at the end exactly half an hour, no, after another extra half an hour at 1 hour period. So back again, what's the justification? Why to give a group of patients the 120 milligrams over 1 hour, and another group of patients or in other circumstances give the patient the 120 milligrams over half an hour? As you can see, Cmax differs. Cmax, when you are giving the 120 milligrams over half an hour, the Cmax here, you can read it, is around 9 micrograms per milliliters. While if it is to be given over 1 hour, the Cmax will be only around 5 micrograms per milliliter. This is the major advantage of giving the drug over half an hour. Okay? Now, as you can see, that the therapeutic steady state peak concentrations for gentamicin, tobramycin, and nitlimycin, these are 3 different examples for aminoglycoside bactericidal antibiotics: genta, tobra, nitlimycin. The therapeutic steady state peak concentration generally ranges between 5 to 10 micrograms per milliliters, and this was clear in the previous slide, in the plot previously. This is for gram-negative bacterial infection. And this is the peak, steady-state peak concentration. You know what do I mean by peak concentration, okay? Let's see if we can draw something with our pen now. Okay, so peak trough. This is the peak, and this is the trough concentration. So the peak concentration, look at this, peak concentration, it's around 5 to 10 micrograms per milliliters. Okay, for gram-negative infections. Now, infection sites with more susceptible bacteria, such as intra-abdominal infections, usually can be treated with steady-state peak concentrations at a lower end of this range, which is typically 5 to 7 microgram per milliliter. Back again, what's the difference between both? In the above paragraph, we are talking about gram-negative bacteria, which is highly infectious and relatively highly resistant. We need higher peak concentrations, which is usually for the aminoglycosides, which is usually ranges between 5 to 10 micrograms per milliliter. While for more susceptible bacteria that is not resistant, which is intra-abdominal infections, the peak concentration could be a little bit lower than 5 to 10 microgram per milliliter. It could be 5 to 7 microgram per milliliter. So for the intra-abdominal susceptible bacterial infections, we can lower down the peak plasma peak concentrations for these aminoglycosides instead of achieving 5 to 10 microgram per milliliter. Simply 5 to 7 micrograms per milliliter will be sufficient to treat such infections. Infection sites that are difficult to penetrate and with bacteria having higher minimum inhibitory concentration values, such as pseudomonal pneumonia, التهاب ذات الرئة, usually require, guess what? A higher, more and more peak concentrations should be achieved to treat such bacterial conditions. So steady-state peak concentrations, look that we are usually talking about peak concentrations. We didn't yet now mention anything about the trough concentration. So the peak concentrations are in the higher end of the range, typically between 8 to 10 microgram per milliliter. So up to now, we have talked about 5 to 10 microgram for gram-negative, microgram per milliliter, then 5 to 7 highly susceptible, relatively highly susceptible abdominal infections, 5 to 7 microgram per milliliter peak concentration values. And for the pseudomonas pneumonia, we should have higher peak concentrations between 8 to 10 microgram per milliliters. With gentamicin, tobramycin, or nitlimycin, they are used synergistically with penicillin. You do know what's the meaning of synergistically. Okay, synergistic, they are giving similar pharmacological effect or similar pharmacological response. Or other antibiotics for treatment of gram-positive infections such as infective endocarditis. So in the case of infective endocarditis, we are using the aminoglycoside synergistically with penicillin. So we are using both drugs, penicillin and one of the aminoglycosides, whether gentamicin, nitlimycin, or topramycin. So because we are using two drugs for these gram-positive infections that are causing infective endocarditis, so the steady-state peak concentration should be lowered for the aminoglycoside. It could be up to 3 to 5. We are talking back again, look at this peak concentration. It should be lowered 3 to 5 microgram per milliliters. They are often times adequate Now the question, why we didn't use higher peak concentrations like what have been mentioned previously, which is 5 to 10 or 5 to 7, okay, or even 8 to 10 microgram per milliliters. In the previous cases, it was the aminoglycosides have been administered individually alone to treat the infections, whether Pseudomonas pneumonia or the susceptible abdominal infections, intra-abdominal infections, or even the gram-negative infections. But in our case, with the gram-positive infections, like infectious endocarditis, we are not only using alone the aminoglycoside. No, we are using the aminoglycoside plus penicillin. Both have synergistic effects, so there is a need to lower down the peak therapeutic concentration of the aminoglycoside into 3 to 5 microgram per milliliters. Now, the therapeutic peak concentration for amikacin. All the previous have been mentioned for aminoglycosides, which are gentamicin, tobramycin, and nitlimycin. Now, let us talk about the amikacin aminoglycoside. For amikacin aminoglycoside, the usually therapeutic peak concentration is 15 to 30 micrograms per milliliter. It's very similar to the unit of milligram per liter. They are equivalent, i.e., 15 to 30 microgram per milliliter is highly equivalent to 15 to 30 milligrams per liter. So exceeding the peak steady concentrations of 12 to 14 microgram per milliliters for gentamicin, tobramycin, or nitlimycin, or exceeding the peak concentration of 35 to 40 microgram per milliliter for amikacin when using conventional dosing, look at this, conventional, taqlidi. We didn't make any modification for the dose. Any exceeding for these peak steady-state concentrations will lead to an increased risk of ototoxicity. You know what is ototoxicity? Ototoxicity, loss of hearing. Okay? So back again, regarding these different concentrations, you should be able to memorize these values. You should memorize the peak therapeutic concentrations for aminoglycosides given for treatment of different situations. Okay, we have mentioned just previously 4 different situations, one with penicillin and the other 3 without penicillin. And now the 5th condition is for amikacin, which usually needs higher therapeutic peak concentration achieved in order to achieve pharmacological response. Okay, don't exceed this peak therapeutic concentration, otherwise it will end up with ototoxicity. So keeping the peak and the trough concentration, now here is the first time we are mentioning back again the trough concentration. I have just explained it in previous slides, and now I will explain it back again what is mentioned by trough concentration. Okay, so this is peak concentration, and this is trough concentration. Okay, so So keeping the peak and trough concentrations within the suggested ranges of therapeutic concentration does not completely avoid the nephrotoxicity and ototoxicity in patients, but hopefully it will decrease the likelihood that the patients will experience these serious adverse effects. So, of the major adverse effects for aminoglycoside group or class of antibiotic is their nephrotoxicity and ototoxicity. We should be strictly adherent to the therapeutic concentration. We shouldn't exceed the peak and even the trough concentrations. We should be restricted to these values. Otherwise, the patient will be highly exposed to the adverse effects of nephrotoxicity and ototoxicity. Now, back again to the concentration time plot for concentration time, y-axis and x-axis. Time plot for gentamicin 120 milligrams given as half an hour. Now you have understood which one has been given as half an hour and which one has been given as a complete 1 hour. Squares for half an hour and the circles for 1 hour. And previously we have mentioned why to give it as half an hour, just to reach the maximum concentration of 9 micrograms per milliliter. Now, when given as half an hour infusion, the end of infusion concentrations are higher. End of infusion concentration exactly at half an hour. You are giving the 120 milligrams over half an hour only because the serum tissues are not yet in equilibrium with the drug concentration in the serum is not in equilibrium with the drug concentration in tissues. For this reason, the drug concentration in serum is high, and according to the previous plot, it reaches around 9 micrograms per milliliters. Okay? Half an hour waiting time for aminoglycosides distribution to the tissues is allowed before the peak concentrations are measured. Why to wait half an hour? Because you want to be sure that the concentration of the drug after equilibrium between blood and the tissues is in the therapeutic range, peak therapeutic range, to achieve the pharmacological response. What's the pharmacological response? It should be bactericidal, okay, against the gram-positive, gram-negative bacterial infections or whatever. If the aminoglycosides are given as a 1 hour infusion, the distribution has an opportunity to occur during the infusion time, and the peak concentrations can be obtained immediately, which is usually lower than that value after compared to the 1 hour infusion. Now, the manufacturer's recommended doses for conventional dosing. Back again, what is meant by conventional dosing? Conventional dosing تقليدي without any modifications in patients with normal renal functionality. Why we are focusing on renal functionality? Because we have mentioned previously, just a few slides previously, that the drug is extensively, the aminoglycosides are extensively eliminated or entirely eliminated through the renal route. What is meant by entirely? Nearly completely, okay? So patients with normal renal function, the recommended doses for conventional dosing is around 3 to 5 milligrams per kilogram per day for gentamicin and tobramycin, 4 to 6 milligrams per kilograms per day for nitlimycin, and 15 milligram per kilogram per day for amikacin. These amounts are divided into 3 equal daily doses. This is the dosage regimen recommended for gentamicin, tobramycin, or nitlamycin, or only 2 or even 3 equal daily doses for amikacin. Okay? So back again, I just want to discuss with you the issue of the dose to explain it back again for you. Okay. Now, let us take a case in our example that we are talking about the 5 milligram per kilogram per day of gentamicin. Okay. So let us suppose we are talking about 70 kilogram patient body weight. Okay, so 5 multiplied by 70 will equal how much? 350 milligrams per day. Yes, we are calculating the dose like this. Okay, now it should be divided, this amount should be divided into 3 equal doses per day, okay, for gentamicin and tobramycin. So 350 divided by 3 different doses, it will equal around 117, okay, milligram per dose. Okay, it should be given TID. What do we mean by TID? 3 times a day. And this is exactly very near to what we have been explaining previously of giving 120 milligram either for half an hour or 1 hour infusion period. Okay, so this is simply to show you from where we have achieved the 120 milligrams that have been previously explained to you. Okay. Back again, you should be able to memorize these values. Where for gentamicin, tobramycin, it's 3 to 5 milligrams per kilogram per day. For this is for the normal renal function. For nitlamycin, it is 4 to 6 milligrams per kilogram per day. For amikacin, it's 15 milligram per kilogram per day for normal renal functionality. For gentamicin, tobramycin, nitlamycin, the doses are divided by 3. But for amikacin, it could be either divided by 2 or 3 doses per day. Because aminoglycoside antibiotics exhibit concentration-dependent bacterial killing, as you are increasing the concentration, you will achieve more bactericidal effect. Okay? And the post-antibiotic effect is longer with higher concentrations. It will be persisting for a longer time, the bactericidal effect for the aminoglycoside. Investigators began studying the possibility of giving the higher dose of aminoglycosides once a day. We are usually afraid of nephrotoxicity and ototoxicity. But why they are thinking about the possibility of giving the drug with a higher dose as once daily, for example, in the previous example, 350 milligrams per day as once, because they have noticed that As the concentration increased, the bactericidal effect will be achieved more with prolonged effect after drug administration. Generally, these studies have shown comparable microbiological and clinical cure rates for many infections and about the same rate of nephrotoxicity, problem with the nephrons of the kidney or urinary tract system, which is around 5 to 10% as with the conventional dosing. So they have tried these approaches and they have found what I mean by these approaches: to give the drug as one single large dose instead of giving it into three individual smaller divided doses to achieve higher bactericidal effect with a prolonged uh, persistency of bactericidal effect. And the clinical studies had showed that either giving it as three divided small doses or one single large dose, the nephrotoxicity occurs in the same value, which is around 5 to 10% of the patients. Because of the extremely high peak concentrations obtained during extended interval dosing of aminoglycosides, it can be difficult to understand why increased toxicity is not seen in patients. So this is to tell you that although very high peak concentration has been obtained when we are giving just single large dose per day, but we are giving large dose, but the increased nephrotoxicity hasn't been seen in the patient. The hypothesized reason is that both nephrotoxicity and ototoxicity are due to accumulation of aminoglycosides in the relevant tissue. Because the dosage interval is prolonged and extended interval, it is given just once a day. The aminoglycosides concentrations are low for a long period of time and may allow for diffusion of the drug out of these tissues and into the blood, which avoids drug accumulation in the ear and the kidney. So the explanation that although we are administering very high dose once a day, but the nephrotoxicity hasn't been observed, the explanation that because it is a prolonged period of time, the drug accumulation inside the tissues, whether kidney tissues for nephrotoxicity or in the ear tissues for ototoxicity, hasn't been noticed. There was no or the concentrations accumulated inside the tissues are low due to the prolonged period of time of a drug administration. So, for this reason, it has been avoiding the drug accumulation in the ear and the kidney, and the nephrotoxicity and ototoxicity has been decreased. Now, the extended interval doses obtained from the literature for the patients with normal renal function these are the extended interval doses, are 4 to 7 milligrams per kilogram per day for gentamicin, tobramycin, or nitlimycin, and 11 to 12 milligrams per kilogram per day for amikacin. So back again, you should be able to memorize these values, that the extended interval dosing once a day for gentamicin, tobramycin, nitlamycin, it is around 4 to 7 milligrams per kilograms per day. Previously, I have, for example, calculated for you in the previous slide for gentamicin when it is 5 milligrams per kilogram, for example, 70 kilogram patient, 5 multiplied by 70, it is 350 milligrams per day. So when you are talking about 7 milligrams, for example, for 70 kilogram patient, you are multiplying 7 by 70, it will be around 490 milligrams per day. If he is the patient 100 milligrams per weight, 7 by 100, it will be 700 milligrams per day, and so on. And consider that it is for amikacin higher value, which is 11 to 20 milligrams per kilograms per day. Imagine 20 milligrams if the patient body weight is 100 milligrams, so he will take 2 grams per day. 20 by 100 will be 2000 milligrams, which is 2 grams. Now, the aminoglycosides steady state peak and the trough serum concentrations should be measured. Peak and the trough. I have told you previously about these two values. So back again. This is the concentration, CP usually. Serum concentration versus time curve. Okay. Drug concentration in the plasma. The drug having peaks and trough. Peak and trough concentrations. Okay. So for aminoglycoside steady state peak and trough serum concentrations, it should be measured in 5 estimated half-lives. The practical steady state, 5 estimated half-lives of the drug when the drug is given using conventional dosing approaches. Steady state serum concentrations in conjunctions with the clinical response. What is the clinical response? There is a relief for the infection. The inflammation parameters has been reduced. There is no infection. Are used to adjust the antibiotic dose if necessary. If the clinical response, there is an indication of higher infection, okay, you can increase the antibiotic dose. Now, when extended interval aminoglycosides therapy is used, several different monitoring techniques can be used. Extended interval aminoglycoside therapy, what is meant? Instead of administering the drug into 3 divided doses per day, small doses, just giving the drug as one large dose, single dose daily. Some clinicians measure the steady-state peak and the trough concentrations, while others measure 2 steady-state post-dose concentrations. Remember that it could be achieved after the practical steady-state and estimated 5 half-lives. While others measure 2 steady-state post concentrations. Other approaches include obtaining only a steady-state trough concentration or measuring a single aminoglycoside serum concentrations 6 to 14 hours after a dose, and using the dosage nomogram to adjust the dosage interval. You know what is dosage nomograms? Nomograms ready-made charts. charts جاهزة بتربط مثلا البيشنت age and or conditions or criteria clinical diagnosis test with the appropriate dosage to be given. Okay. Serial monitoring of the serum creatinine concentrations should be used to detect nephrotoxicity. If the creatinine clearance is decreased and the creatinine accumulation concentration is increased in the blood, it is an indication of nephrotoxicity for the kidney tissues. Okay. Now, here is a relationship between the renal and aminoglycosides elimination. This is the creatinine clearance milliliter per minute, which is an appropriate indication for the renal clearance. And this is the elimination rate constant, which is a good indication for the aminoglycoside clearance. This is the elimination rate constant. K value, unit of it is the time inverse, which is an hour inverse. And this here is the creatinine clearance, which is representing the renal clearance as milliliters per minute. As you can see here, there is a direct correlation between the creatinine clearance and the drug clearance or elimination. If the creatinine clearance is decreased due to nephrotoxicity, so the rate of drug elimination will be reduced. There will be more accumulation of the drug inside the body and more nephrotoxicity and ototoxicity. The elimination rate constant for aminoglycoside antibiotics increases in proportion with the creatinine clearance. The equation for this relationship is K an hour, which is the elimination rate constant for the aminoglycoside, our inverse, equal 0.00293 creatinine clearance in milliliters per minute. This is the slope value, which is 0.00293 plus 0.014. 0.014 is the non-renal clearance for the aminoglycosides. This equation is used to estimate the aminoglycoside elimination rate constant in patients for initial dosing purposes. Okay? Let us take a practical example, okay, to calculate the conventional dosing administration for aminoglycosides. Now, JM is a 50 years old. He is 70 kilograms. His height is 5 feet and 10 inches. He is a male with gram-negative pneumonia. Okay. So, as you can remember in the slide number 12, for the gram-negative pseudomonal pneumonia, the appropriate steady-state concentration is 8 to 10 micrograms per milliliters. So his current serum creatinine, this is serum creatinine, not drug concentration, is 0.9 milligrams per deciliter. Back again, deciliter mean 100 milliliters, okay? So it is also 0.9 milligram percent or 0.9 milligram per 100 milliliters. And it has been stable over the last 5 days since admission. The serum creatinine concentration. Compute gentamicin dose for this patient using the conventional dosing. Now I'll stop here to refocus back again that when I have explained the dosing administration, there is a conventional way and or conventional dosing and an extended interval dosing. We have talked about two different dosing approaches. The conventional dosing, the slides have been highlighted initially. The heading is with blue highlighting, while for the extended interval approaching, it is being highlighted with a pink color. The heading is pink color. The major difference between both extended interval approach or the conventional approach. Conventional, the dose is given over as divided 3 doses per day for gentamicin, tobramycin, and nitlimycin, while for amikacin it could be 2 or 3 times daily. While in the extended interval dosing, the dose will be increased and given once daily. And we have talked previously about justifications why to give extended dosing rather than or extended interval dosing rather than conventional dosing technique. Okay. And we have talked previously about the clinical monitoring parameters, which are the steady-state peak and trough concentrations with the clinical response, and to be estimated just 5 half-lives after administration, What are the parameters? Clinical monitoring parameters and clinical pharmacokinetic parameters. Now, he wants us to compute the gentamicin dose for this patient using the conventional. When we are talking about conventional, so the dose should be given with, and it is gentamicin 3 times a day. Now, to estimate, first of all, the creatinine clearance, the patient has a stable creatinine clearance and he is not obese. His weight is only 70 kilograms and his height, this is around, I think, 160 centimeters. Now, the Cockcroft-Gault equation can be used to estimate the creatinine clearance. Where creatinine clearance, you should rememorize back again. Cockcroft-Gault equation is 140 minus the age multiplied by the body weight divided by 72 multiplied by the serum creatinine values, which will equal 140 minus 50 years. He is 50 years old, multiplied by 70 kilograms divided by 72 multiplied by the serum creatinine, which is 0.9 milligram per deciliter. Take care that it is here per deciliter, i.e. 100 milliliters. The creatinine clearance is 97 milliliters per minute. Please take care, it is here per 100 milliliters here instead of deciliter. After you are calculating the creatinine clearance, we will estimate the elimination rate constant and the half-life. The elimination rate constant versus creatinine clearance relationship is used to estimate the gentamicin elimination rate for this patient. The elimination rate constant, the equation has been previously mentioned, okay, which is K will equal 0.00293 multiplied by the creatinine clearance, just we have calculated in the previous slide, which was equal to 97 milliliters per minute plus 0.014, okay, so multiplied by 97 plus 0.014, it equals the elimination rate constant is 0.298, our inverse. The t-half will be 0.693 over the elimination rate constant, which will equal 2.3 hours, okay? We are making all of these calculations just to be able to compute the gentamicin dose for this patient using the conventional dosing. So first of all, we have calculated the creatinine clearance according to Cockcroft-Gault equation, which equals 97 milliliters per minute. Then we apply it in the equation to calculate the elimination rate constant and calculate the half-life of elimination for this patient. And next, we should be able to estimate the volume of distribution for this patient. The patient has no disease states or conditions. We haven't been notified by the example that he has certain disease states that would alter the volume of distribution from the normal value. So you can take it as 0.26 liter per kilogram or 0.25 liter per kilogram. It is around, his body weight is 70 kilogram. It is around 18.2 liters. Now, you can choose the desired steady-state serum concentrations. He is having gram-negative pneumonia. You can remember that it should be the peak between 8 to 10 micrograms per milliliter. So the patients treated with aminoglycoside antibiotic require steady-state peak concentration, steady-state maximum steady-state concentration equals to 8 to 10 microgram per milliliter. The trough concentration, minimum steady-state concentration should be around 9 microgram per milliliter to avoid the toxicity. So set maximum steady-state concentration as 9, taking an average value for this, and minimum steady-state concentration as 1 microgram per milliliter. So back again, we can use the intermittent intravenous infusion equations taken previously in the previous lectures with Dr. Hadil, okay, to compute the dose. you can calculate the required dose interval tau using a 1 hour infusion, where minimum steady state concentration dividing maximum steady state concentration will equal e to the power k multiplied by tau, which is 1 hour infusion instead of half an hour, minus the t time at infusion. So tau will be equal ln maximum steady state minus ln minimum steady state over k plus t time required for time at infusion. So ln 9 microgram per milliliter minus ln 1 microgram per milliliter divided by 0.29 it has been calculated the elimination half-life plus the time for infusion will equal as 1 hour. It will equal 8.4 hours. So the dosage intervals should be rounded to clinically acceptable intervals to 8 hours. Now we use the intermittent intravenous infusion equation to compute the dose. All of these steps are required to compute the dose. Now the maximum steady state concentration will equal Q multiplied by 1 minus e to the power minus kt infusion over V multiplied by K multiplied by 1 minus e to the power minus k phi tau. So Q will equal steady state maximum steady state concentration multiplied by K phi V multiplied by 1 minus e to the power minus k phi tau multiplied by tau over or divided by 1 minus e to the power minus kt infusion. So Q will equal 9 milligram per liter, which is the maximum steady state concentration, multiplied by 0.298 elimination half-life, multiplied by volume of distribution, multiplied by 1 minus e to the power minus 0.298, multiplied by tau, interval which is 8 hours, divided by 1 minus e to the power minus e to the power minus 0.298 hour multiplied by 1 hour, which is the infusion time. T infusion is different from tau. This equal 172 milligrams given 3 times daily for this 70 milligram body weight patient. Okay. Now to compute the loading dose if needed, it equals the maintenance dose Q divided by 1 minus R. Q 172 milligram divided by 1 minus e to the power minus kt, 1 minus e to the power minus 0.298 tau, which is 8 hours, and the loading dose will be equal 187 milligrams. The maintenance dose, we will continue with 172 milligrams 3 times daily. Like this, we have finished our lecture for today. Feel free to ask me any question. I will open discussion board through the whole week. Just feel free to ask me any question at any time. And Mrs. Naifa will make the tutorial session for you just on next Tuesday. Don't forget to upload your assignments for week 9 as well as for week 10. أمنياتي لكم بالتوفيق دائما وأبدا، والسلام عليكم ورحمة الله وبركاته.